Good morning. I am honored to be giving the Charles Daughter Lecture this year. First, I want to thank you, Laura, for that kind invitation some 18 months ago, but I couldn't have imagined at the time that I'd be giving it from the comfort of my own home. And I also want to thank the annual meeting committee for moving the talk that never happened to this year's program. And finally, I want to recognize my faculty colleagues and the hundreds of IR fellows and residents I've worked with at UC San Diego and the University of Washington here in Seattle over the last 30 years. You've been my inspiration through this incredibly rewarding career. I think you'll all agree we work in a fantastic specialty. I've not forgotten what my mentor Joe Bookstein once jokingly said to me long ago about being an interventional radiologist. I can't believe they pay us to do this. It goes without saying that this past year has brought challenges and uncertainty that few of us have faced in our lifetimes. The political and cultural divisions are so deep and so wide that I sometimes fear for the future of our country. We've seen in graphic detail too many instances of hostility and injustice that seem endemic in our country and that we just can't continue to ignore. I think the recent words of playwright August Wilson captured the sentiment of many of us when he said, "We're all feeling the need to confront the dark parts of ourselves and work to banish them with illumination and forgiveness." In our own specialty, we have a lot of work to do to increase diversity, equity, and inclusion. And on top of all that, the pandemic has created this dark cloud that has overshadowed everything. The virus has claimed millions of victims around the world, brought sorrow and pain to countless families, and diminished everyone's life. But, and I know it sounds cliche, this disaster has made us take stock of our values and our priorities, and given us lots of gratitude for what we have. I want to recognize the selfless and heroic efforts that so many of you have made in caring for your patients during this difficult year. I've seen it in my own practice, and I have every reason to believe it's the norm. You and your IR teams went to work day after day, facing a threat that could sicken you, or worse, that you could bring home to your loved ones. That is true courage. But the topic of my talk today is something entirely different. I'd like to speak about what I believe is the fundamental question we need to ask about every patient referred to us in interventional radiology. That is, why are we doing this procedure? And by that I mean several things. Should we be performing an intervention on this patient at all? Should we be doing it with these tools or techniques that are brand new to the field or new to us? And really, where is the patient ultimately headed by doing this procedure? Now, it seems like the most obvious and basic question to consider before any case we do. And much of the time, we ask it and have an acceptable answer. But all too often, we don't. I find myself asking it more and more often during our morning work conference after the details of the procedure have been presented. Why are we creating a TIPS on this patient with 3 months to live? Why are we draining this fifth fluid collection when the patient really needs an operation? Why declot this thrombosed dialysis graft 2 weeks after placement when we know it won't stay open for long? Does this IVC filter really need to come out? I think the repeated disregard of this matter is widespread. For years, during IR residency interviews, I've asked applicants from around the country, among other things, what bugs them the most about IR when they rotated on the service. By far, the number one answer: attendings agreeing to do a case simply because a provider requested it, even if they thought it was the wrong thing to do. Now, obviously, residents and medical students don't have the experience and perspective that we older folks do, but sometimes out of the mouth of babes. So we have to face this uncomfortable subject head on. As a specialty, we've committed ourselves to becoming true clinicians in the eyes of our patients and our referring providers. To do that, we need the knowledge base and clinical skills to manage our patients for the long haul so that we rely less on other doctors to do that job. We need our own clinics and inpatient admitting teams and consult services. But to me, these things aren't enough. Clinician implies thinking first and foremost about a patient's well-being as she or he defines it, and intervening only to work towards that end. And sometimes that means not doing a procedure just because we can do it or because we're asked to do it. To look at this problem, I think we need to understand the factors that make us sometimes behave more like a technician than a clinician. The origins of interventional radiology play a big part. We grew out of diagnostic angiography, and the early pioneers in our field were trained as diagnostic radiologists. We got an order for an angiogram and we did it. We didn't see the patient beforehand. We didn't care for the patient afterwards. We saw an abnormality on an imaging study and figured out a way to fix it if the clinician accepted our offer. And now, despite impassioned claims to the contrary, that tradition of providers ordering procedures and IRs complying with them is still very much with us. We did listen to Doddard's prescient warning and created a new clinical specialty of medicine for ourselves. But sometimes we still act like and are viewed as glorified technicians. We do the case simply because it's on the schedule or because the provider or the patient or the family insists. And frankly, sometimes it's just easier to do it than fight it. I grant you that in IR, we often enter a patient's care pathway after a long period of complex management has unfolded. Many decisions about the treatment plan have been made. Questioning the appropriateness of a procedure having just learned about the patient can be awkward and difficult. And IRs are rightly concerned that sometimes putting up roadblocks may lead to loss of work or complaints to administration that are annoying at best. This situation is especially true in private practice, but academic groups aren't immune. And for these and other reasons, we simply end up complying with the request. Second, despite our best intentions, sometimes we fall into the trap of focusing on the way to fix an imaging abnormality rather than considering first how that repair might actually help the patient. The examples are endless. Consider a person with a very small dysplastic splenic artery aneurysm. Absent some aggravating factor, it doesn't need to be repaired simply because it's there and simply because we can do it. Or a person with subacute portal vein thrombosis and partial response to anticoagulation. Will a complex thrombolysis procedure change the ultimate clinical outcome? Or finally, a cirrhotic patient with refractory ascites and fairly good liver function sent to us for tips. We can easily just do the case, but if the patient's biggest fear is confusion and memory loss from worsening encephalopathy, what have we really accomplished? Third, like it or not, money matters, and the financial challenges facing IR grow by the year. We see an ever-increasing caseload, which gives us less time to devote to non-procedural work. There's continued loss of major and minor procedures to other specialties. For many of the things we do, reimbursement has been on a steady decline. And the compensation we do get for evaluation, management, and coordination of care loses out every time to doing more cases. Given all that, we're not very inclined to refuse procedure work. Fourth, probably more than any other specialty in medicine, we're dependent on devices. And the very culture of IR drives us to be aggressive in inventing and then quickly adopting new tools and techniques. But we need to be wary of several players in this business. First, the medical device industry. Of course, without these companies, our whole field couldn't exist. We genuinely value the partnerships we've created with them, partnerships that have improved the lives of countless people around the world. We may dream that their first priority is the public good, since they hold the public's welfare in their hands. But this is ultimately a profit-driven industry with very aggressive and effective marketing strategies. The goal is to sell as many units as possible. And also, we know that whenever doctors and companies become bedfellows, conflicts of interest can't follow. The FDA is another concern. The vast majority of our devices are approved through the so-called 510(k) process, which is faster and cheaper and more lenient than pre-market approval mechanism. That pathway, the one required for prescription drugs, demands proof of safety and efficacy. In a 510K review, the FDA considers whether the new product is substantially equivalent to an already approved predicate device that's been chosen by the sponsoring company. That older product may be quite dissimilar, and its safety and efficacy may never have been proven. Now, granted, this route has allowed many important IR tools to quickly enter practice, and a great many patients have benefited, but it's seriously flawed. In 2011, the Institute of Medicine recommended elimination of the 510K pathway altogether. And a recent opinion piece in the New York Times warned that the FDA has also become profoundly vulnerable to political interference and other special interests. There is a deep tension between groups that want medical products to be proved safe and effective before they are made widely available, and those that say as long as those products pass a bare minimum of safety testing, patients will be able to decide for themselves. So we really can't count on industry or government to keep patients safe. In the early days of IR, much of our research was fairly crude and the regulatory climate fairly lax. New devices and new procedures spread rapidly into general practice, often well before we could show their benefit or safety. We certainly have raised our standards since that time, but this tendency to ride the wave of a brand new technique or tool still lingers. The result? Premature adoption of a procedure or protracted faith in one that sooner or later turns out to be of questionable value or downright dangerous. Think first-generation laser atherectomy devices for PAD, the G2 and recovery IVC filters, routine renal artery stenting for atherosclerosis, renal denervation for hypertension, jugular vein stents for multiple sclerosis. Now, Dotter set the standard for the idealized interventional radiologist: creative, aggressive, keen to innovate on the spot, and willing to take risks. And those were common traits of many of the pioneers who founded our specialty, and of the second and now third generation IRs who followed. It's a testament to our field that many doctors think of IRs as the great innovators in procedural medicine. We offer to fix problems when even the surgeons can't or won't, often becoming the last resort in desperate situations. But this ethos feeds into the notion of the IR as superhero. We quickly applaud colleagues who invent novel devices or innovate right on the table to accomplish the seemingly impossible. We see this all over the place, in the medical literature, in extreme IR forums at meetings, or the high fives we share after we finish an especially difficult case. Is that a problem? Well, largely no. But this attitude can lead us astray when we don't ask, first and foremost, what is the real value of that procedure to our patient? The pressure from doctors for us to forge ahead in questionable cases can be hard to challenge. And demands come from patients too. The physician-patient relationship has evolved over time from a paternalistic model to a collaborative, or you might say customer-driven one. And the entire body of medical knowledge has become available on the internet to almost everyone, even if it's not comprehensible to most. So patients and their families have become more aggressive in asking for procedures to be done, even when they're simply unnecessary or just plain crazy. And finally, our practices have become so busy and chaotic that patients requiring the simplest of procedures sometimes get neglected. Think of someone coming in for a routine change of a nephrostomy or biliary catheter. The case is usually simple and forgettable, and so we may give very little thought to the long-term plans for that patient. Really, we're simply kicking the can down the road until the next catheter change. They turn into department regulars that become friendly with the entire IR staff, but some of them are essentially medical orphans. They've been forgotten by referring providers, and we in IR haven't taken charge to create a plan towards getting that catheter out. Now, we're certainly not the only culprits. On the whole, our nation's healthcare system does a woefully bad job of maintaining ownership of people with complex or chronic health problems, and with communicating with patients and families. The findings of a recent report by the Institute of Medicine are very disheartening. Nearly half of patients report difficulties with care coordination and communication between primary providers and specialists. Fewer than half of patients believe they have received adequate information about the relative trade-offs of treatment options offered to them, and fewer than half are satisfied with the level of involvement in decision-making. And physicians stress benefits of interventions over discussion of risks and ask for patient preference only half the time. In the Dotto lecture 2 years ago, Alan Matsumoto warned us about this bystander effect, where multiple individuals or teams are involved with the care of a patient, but no one takes the lead. Lisa Rosenbaum is a cardiologist at Harvard who recently wrote a commentary in the New England Journal of Medicine about this very issue. She called it the "not my problem" problem. In an embarrassing reference to our own specialty, she described a patient with a percutaneous cholecystostomy catheter who was transferred to her hospital from another facility. Her hospital IR group learned about the patient, but failed to take charge of catheter management. That left one of the consultant physicians to do the job because it was the right thing to do. The work that needs to be done in these situations is often mundane and time-consuming, but in the eyes of other providers and patients and their families, it's the mark of a truly dedicated clinician. Now, don't get me wrong. I think this is an incredible specialty, one of the best in medicine in all kinds of ways. And IRs are certainly among the hardest working and most dedicated doctors to be found. But we can do better, a lot better. First of all, we must be our own gatekeepers for the procedures we invent. We should always be open to adopting new ways to treat patients, but each of us needs to keep a healthy dose of skepticism about every new device or technique that comes down the pike. The government approval process is flawed, and oversight of devices after they enter the market is thin or non-existent. Changes in FDA regulation of medical devices are long overdue. We need to have strict compliance with rules that are already in place for global post-market surveillance of permanent medical devices. FSIR is working directly with industry. Bias can be very hard to avoid. And make no mistake, it doesn't only come from financial incentives of one sort or another. It can come just as easily from genuine, unbridled confidence in the devices these doctors have developed or promoted. So whenever a new product is introduced, we ought to follow the advice of expert thought leaders in IR with no financial ties to that company or any of its competitors. We need to challenge requests for procedures that are not indicated, unlikely to succeed, or simply futile. Granted, it's hard to maintain a pattern of even appropriate resistance to requests from providers, but we owe it to our patients to make that effort and take that risk. When someone calls us about a complex clinical problem or a desperately ill patient that no one else can or will help, we need to first ask ourselves, should we do anything at all? If so, is the intervention likely to work? Is the potential gain worth the risks involved? And even if the result is a technical success, which we can read as gratifying post-procedure image, will it last? And what is the real benefit to the patient in the long run? After we do any IR procedure, no matter how simple, we need to ensure that someone has or will take ownership of that clinical problem. Ideally, if we leave a catheter or device in the body, it's ours. We shouldn't delegate responsibility for management or follow-up to someone else. We have to improve communication between patients and families in the IR team. And messages should be frequent and consistent. All the patient's healthcare providers down the line need to understand the plan. And if someone does get lost in the system, it's our job to work with the appropriate specialty to take charge and manage that clinical issue. For people who are gravely ill or nearing the end of life, there are times when an IR procedure is appropriate, even though it's unlikely to change the outcome. For example, we may do it to ease the emotional transition for patient and family from doing everything possible to palliation and end-of-life care. But in general, it's our responsibility to avoid procedures that are not appropriate, simply to satisfy a referring doctor or a patient, especially if they're unsafe or frankly useless. Dr. Nancy Jecker is a well-known bioethicist at the University of Washington who's written extensively on this subject. She believes that physicians have no obligation to offer treatments that do not benefit patients. Futile interventions may increase a patient's pain and discomfort in the final days and weeks of life, give patients and family false hope, delay palliative and comfort care, and expend finite medical resources. To be really worthy of the title clinician, we can't evade our responsibility to start these difficult conversations and help our patients make the best decision about a procedure. When I'm faced with a dubious request for intervention on a patient with a very long or complex disease course, it can feel like I'm jumping on board a runaway train with no power to slow it down. But sometimes we need to be the ones to do just that. Hold up a sign that says, stop. In my experience, providers and patients are often grateful that someone had the fortitude to force everyone to be realistic and change the direction of care. And finally, we have to have honest conversations with patients about what really matters to them. Many IRs do this regularly, particularly in the realm of interventional oncology. But sometimes we're afraid to dash at patients' or families' hopes, even when they're completely unrealistic. Every June, I give each graduating IR resident a copy of the book, Being Mortal. The author is Atul Gawanda, who is a surgeon at the Brigham in Boston, as well as a staff writer for The New Yorker. His book challenges the way many doctors regard patient care, particularly proceduralists involved with very serious diseases. Gawanda thinks that we should stop flogging patients and prolonging suffering with futile medical procedures. We need to talk about death. And we can't afford not to, because the spiraling cost of medical care in the US is simply unsustainable. We can't carry on with a system in which 25% of total Medicare spending is channeled to the last year of life. In the epilogue of his book, Gawanda says that we have been wrong about what our job is in medicine. We think our job is to ensure health and survival. But really it's larger than that. It's to enable well-being. And well-being is about the reason one wishes to be alive. And he goes on, our system of technological medical care has utterly failed to meet the needs and wants of sick people, which is to minimize suffering, maintain contact with family and friends without burdening them, and continuing to find meaning in life. He talks about the work of palliative care specialist Susan Brooks of the Dana-Farber Institute in Boston. To her, the essential questions we should ask patients are, what is your understanding of your health and condition? What are your goals if your health worsens? What are your fears? What are the trade-offs you're willing to make and not make? And what would a good day look like? As IRs, we need to take a more active and visible part in a long and complex arc of patient care for seriously ill hospitalized patients, as well as those with chronic diseases. Now, finally, I have to admit that I am not the best role model for some of the practices I've just promoted. Frankly, a number of my colleagues do a much better job than I do. So I need to heed my own advice. And in several areas, my wonderful section has definite room for improvement. With rare exceptions, none of us wants to ever be thought of as a procedural technician or to behave like one. But only by changed attitudes and sustained behavior can we become the true clinicians to which we aspire. That is my hope for interventional radiology, because it is the right thing to do for our patients. Thank you.